but I want everyone to participate actively. So before I start, I would like to thank my previous institutes from which some of the cases I have collected from these institutes. So that is SGPGI Lucknow, CMC Vellore, and presently in SMVD NH. So William Rongent said, I did not think, I investigated. And the essence of radiology is built on that very same principle, seeing beyond the obvious and investigating what lies beneath the surface. With that theme, let us start with the first case. I will just start with see the chat also. What do you think about this chest X-ray? I hope I can see the chat. Will the message, Dr. Nikshita, will be the message visible in this?
Yes, it will be visible. Even I don't see any messages here yet, actually,
Yeah,
but
I
it
don't know
should be
whether
visible. Mm. They're usually pretty fast, everyone. Even if you're wrong, it's fine, like the meme said. Okay, yeah, we have some
yeah,
answers.
it's coming. Okay, it's coming. So please post as many as answers you can, whether you are right or wrong, mediastinal widening. That's why I have posted these cases so that you get an idea how do we think about those cases and what is the underlying pathology and other things. We'll be little bit quick. So some are saying mediastinal widening, some saying calcific foci in the right scapula. This is, you are right. These are actually the film related. It's an old cassette artifact, maybe something on the cassette that has come. Straightening of the left heart border, superior mediastinal widening, increased bone density. Excellent. So somebody has posted that this is increased bone density. But if I say this is a 30-year or a 40-year male, is this bone density still increased for that male? It may be. For example, for a 40-year male, it may be normal, this bone density. It may not be really increased for a very young male, healthy male. So this is another X-ray. It's a 76-year male. This is the comparison X-ray. And this is a 68-year male. Now compare the two. Yes, the bone density is definitely increased in this one. So that was the point in this one. When you see a radiograph, you have to know the age and other things. Something may be normal for a 30-year male, and the same thing may not be normal for a 70-year male. So if you see this one and compare this one, the bone density is definitely increased even for a young male, and for a 68-year male, the density is definitely increased. So this one was basically a case of CA prostate with disseminated metastasis. The point is you have to know the age and other things to interpret what may appear normal to you may not be actually the normal. So this bone density is not normal for a 70-year male, and this was a CA prostate, and these are the CT images of the same patient. You can see that every bone in this patient was filled with metastatic lesion. All right. So based on the same thing, this is another patient. This is a companion case. This is a 79-year male, and it came to us from the gastrosurgery. So I talked to the gastrosurgeon. It came for splenectomy planning. Patient was outside, diagnosed as NCPF, and that was the clinical details which came to us. So what do you think about this? Excellent. Somebody is saying myelofibrosis. True, very true. So that was when we saw the spleen, definitely it's increased. The splenic vein and the portal vein were dilated. These arteries, the splenic artery was also dilated and tortuous. But again, the suspicion was the patient was very weak. So we weren't expecting this kind of bone density for that male. Usually they are osteoporotic by this age, 80-year male, and this bone density was looking a little bit suspicious. On that very suspicion, and this massive splenomegaly. So we had with bone marrow, and finally it was diagnosed with CLL and myelofibrosis. So the aim is you have to interpret what may appear normal to you may not be actually normal. So keep all those things in mind and then approach a case. This was just a starter for you. Now we will begin with the case one. I hope everyone is ready. This is a 44-year male. who had chronic urinary symptoms. And again, a real life case. Patient was on follow up by a urologist first outside, then came to our hospital for those urinary symptoms. Patient was catheterized, and this was the MRI lumbar spine of the patient. Those who are with me on Twitter, they may have seen this case. I have posted it in Twitter also. So, what do you think about this case? Myxopapillary embryoma cystic lesion. So, this is T2, this is T1, and this is post contrast T1FS, dural ectasia. Okay, this one is perineural cyst. Forget about this one. I'm talking about this lesion. Dermoid. So dermoid will have again this fat component. You can see the it's T1 hyper, but again it's remaining hyper on the post contrast also. It's probably not fat. Myxopapillary embryoma can be solid cystic. Excellent. So all these are very great differentials. Yeah, absolutely. Tethered cord is there. Someone is rightly pointed. The cord is tethered in this one, and there is a heterogeneous signal intensity lesion. On these ones, you that's what I was saying. See, in if you read from the book, it will be saying, for example, this lesion, this SWI is classic, or T1 is classic, or the diffusion is classic. But unless and until you don't suspect that pathology, you may not apply the same kind of imaging sequences. For example, in this one, if you feel it is a mixed papillary adenoma, it will go with that. And on this one, it was not fitting with this. There was this T1 hyperintense component, no definite enhancement. The cord was resolved. It was not looking like a classic this myxopapillary or some schwannoma or something. And somebody may, if you somebody has sharp eyes, somebody may have noticed this focus also. Can you see this focus here? This we couldn't explain what was this focus. So based on the suspicion that it's probably not the routine kind of neoplastic lesion, we called back the patient and did diffusion weighted imaging. What do you think now? Excellent. So this is an epidermoid cyst of the conus medullaris. The point is the key sequence in this one is DWI, but unless and until you don't suspect it, you don't do routinely normally in case in spine. We don't do diffusion weighted imaging. It's difficult to attain good images diffusion in spine, but this is an epidermoid cyst. So point is to suspect some pathology and then you have to do according to that other sequences. So based on the same case, which feature favors a dermoid cyst over an epidermoid cyst in the spinal canal? Simple. We discussed this case. Excellent. So I want everyone to participate. See, it's a dermoid over an epidermoid. If it was an epidermoid over a dermoid, diffusion. But this is a dermoid over an epidermoid. So that's the presence of macroscopic fat. There's no fat in case of epidermoid, isn't it? So this is presence of macroscopic fat signal, which is favors dermoid cyst over an epidermoid cyst. Okay, great. How did you go to diffusion from multiple lesion? Basically, the imaging was not fitting classically with this one, and it was looking like a low-grade lesion. The point above was not fitting. That was basically a localized rupture of this epidermoid cyst. It's a surgically thrown. Okay. So spinal epidermoid cysts, these are intradural lesions at the level of conus medullaris, heterogeneous T2 signal, incomplete flare suppression, as you see in case of intracranial epidermoids, marked diffusion restriction, absence of internal enhancement. So if you see diffusion restriction without enhancement in a conus lesion, it's epidermoid and then prune until proved otherwise. And if you see T1 bright with fat suppression drop, it's a dermoid, and diffusion restriction without fat is epidermoid. So remember 2, 3 pointers. I didn't include much of a theory so that you can read it yourself. We'll go to the case number 2. I hope everyone is ready. 17-year girl with history of skin rash and abdominal pain. Beautiful responses I can see. These are different contrast enhanced images. So what do you think about this case? We'll try to finish as many cases as so that. Today it doesn't remain pending. Beautiful, beautiful. So this is visceral larva migrans. Excellent. So this is visceral larva migrans. So what are the features? You can see usually these linear tract like along which the parasite usually moves. These are peripheral clustered. These are subcapsular along the portobiliary tracts. So if you remember this picture, this is very, very classic of this. This is visceral larva migrans, and they usually have rash because they have usually high eosinophil count. And if you biopsy these lesions, they will show. Usually, biopsy is done to diagnose. If you do biopsy, for example, then you will see typical those charcot-laden crystals and those kinds of eosinophils and other things, and they can present with rash related to that eosinophilia. So remember these features, and this is classical. What was the first case diagnosis? So that was a prostatic CA. If you are talking about that, okay. A patient with suspected hepatic visceral larva migrans undergoes MRI of the liver. Which of the following imaging features would argue against the diagnosis? Now, this is theory. I showed you the image. Now, what do you think about this one? The question is which would argue against the diagnosis of visceral larva migrans? A. Dr. Shweta Singh, A, B, C. Varied responses. Excellent. All those. Okay. Okay. Great. That's why I had this put this question. So there is the classic difference between the routine bacterial abscess and a visceral larva migrans disease. You will not have an abscess wall, a capsule, in case of a visceral larva migrans. So the correct answer is thick, smooth, uniformly enhancing abscess wall. There is no abscess wall in case of visceral larva migrans. It is that larva migrating with associated immune reaction and eosinophilic infiltration and inflammation, but there is no abscess wall. All other features are classic of visceral larva migrans, except this thick smooth. So you don't see an abscess wall. So normally we think that this is product kind of an infection and kind of an abscess. There will be an abscess wall, but there is no abscess wall in this one. Excellent. So it's a dynamic inflammatory tract disease which is caused by the migrating larvae, multiple hepatic lesions of non-round morphology, ill-defined margins, subcapsular and periportal distribution, clustered or a conglomerated appearance, marked diffusion restriction, minimal systemic infection markers, peripheral eosinophilia, that's what I was telling. There's no abscess wall, no double rim sign of pyogenic abscesses, and temporal migration and shape change. That is very, very classic. There are a lot of pathologies in the human body which have this kind of temporal migration. We'll discuss it more. And disproportionate diffusion restriction related to enhancement. There is usually no enhancement, but very strong diffusion restriction in them. And they have a T1 hyperintense peripheral rim. These are some of the features which are usually seen. But if you remember the picture, you will not have to focus on theory too much. Okay. Case number 3. This is a 41-year female with chronic shin pain. Remember it. Oh, ready, everyone? We'll go to the image. These are the three different images of the patient. You can see here. These are three different CT images. Whosoever will get this correct, I will have a personal prize for him. This is an interesting case, intramedullary osteoblastoma, chronic venous insufficiency-related hyperostosis. That chronic venous insufficiency usually have periosteal reaction. You see such kind of intramedullary hyperostosis. Okay, okay. Brody's, Piler's disease, very excellent differential. Intramedullary osteoblastoma. Okay, this is a case of intramedullary sclerosis. I hope some may have heard about this. This is an intramedullary sclerosis, idiopathic intramedullary sclerosis. There isn't an osteodytoma. This is a vascular channel basically. You can see here on this one, this is a vascular channel. This is not an nidus, and there is mild periosteal reaction. This is typically usually seen in tibia, can be seen in female, but it is usually mid tibia, mid diaphysis of the tibia. It is seen in middle-aged females, presents with chronic shin pain which does not respond to the NSAIDs. These are usually minimal periosteal reaction, no associated soft tissue collection, no aggressive periosteal reaction, no cortical destruction. So this is intramedullary, idiopathic intramedullary sclerosis. Remember this diagnosis. These are very rare pathologies, but you may get now and then. So all these are excellent differential diagnoses. This intramedullary osteoid osteoma, classical. Gary's osteomyelitis, I don't think is any more considered as isolated diagnosis. Most of those patients are basically non-bacterial osteomyelitis. I will show you a case. This is Gary's isn't this one now. So there isn't any trauma history on this one. Excellent. So which of the following features most reliably supports the diagnosis of idiopathic intramedullary osteosclerosis? Diaphyseal location with a, oh, this is the case what I shown. Okay, anything else? I will see E. Low signal within the medullary cavity. That will be any sclerosis or even the osteoblastoma also will have low signal. Excellent. D. This is an adult onset, female predominance, and no family history. Remember this one. I will you get to the next this companion case. I will show you why this is adult onset is important. One, osteoblastoma are usually in the first 2 decades. Female predominance is also important. And why no family history? Because there are a lot of these diaphyseal sclerosing dysplasias. They will have definite family history. This is usually focal, unilateral, no family history. Otherwise, the other pathologies like the ribbing disease and other things, they will also have diaphyseal location. They will also be in long bones, but they will have symmetry and they will have family history. This is isolated focal usually. Okay. So this is adult onset with female predominance and no family history. Sorry. So this is benign, mid tibia most common, homogeneous or patchy, often confused. Since the pain is activity related, it is often confused with stress injury. Usually you have minimal periosteal reaction, but no extensive periosteal reaction. Periosteal reaction is minimal. There is no nidus, and that differentiates from osteoid osteoma. No clinical and lab parameters of infection to differentiate it from chronic sclerosing osteomyelitis, which someone was saying, like GAR and other things. There will be no fracture line, and it is asymmetric even when bilateral to differentiate it from other diseases like Adam-Chester and diaphyseal dysplasia. I hope you have somebody who have seen this case before. What are the red flags for this intramedullary osteosclerosis? If you see prominent periosteal reaction, you see soft tissue component. If you see cortical destruction, you see systemic symptoms, or you see multifocal symmetric disease with skull involvement. This will be multifocal will be in case of dysplasia, systemic symptoms in case of osteomyelitis, cortical destruction in case of neoplastic, soft tissue in case of neoplastic, and all those things. So all these will be differentials which you guys have then greatly presented. So all these are the differentials. I will not go to the details. This is the differential. See, this is called the ribbing disease. This will be bilateral. This will be symmetric. There will be no family history. And based on the imaging, the important clue between the two is on radiograph, this may be confused, but this is basically predominantly cortical thickening with encroachment on the medullary cavity. But the intramedullary sclerosis is that is not a cortical based process. Remember, that is a medullary cavity based process. And that is on imaging very important differentiating feature between the two. Mhm. This is the companion case. Okay, great. This is a 24-year male. Next case. This is case number 4. 24-year male with altered sensorium. And this is again a real life case. This was a very young male who came to us in altered sensorium. Later on, after seeing the images, we retrospectively asked about the other histories and we came out with the final diagnosis with who underwent dental extraction outside. under anesthesia and then came to us with these images. Nothing much on the SWI, nothing much on the other sequences. These are the images. I hope somebody comes with some nice diagnosis. Please show the differentials again of the previous case. I will come to it. Okay, okay, just a see, these are the differentials: osteosarcomas, lymphomas, osteoblastic metastases, osteoblastoma, chronic osteomyelitis, healing stress fractures, metabolic disorders, and sclerosing bone dysplasia. Hypoxia, anything else? Local anesthetics, asymmetric bilateral findings in particular territories, toxic insult, and Dr. Nikshita. Okay, this is typical. This is the Chanter syndrome. This is very classic. You will see cerebellar, you will see bilateral hippocampi, you will see basal ganglia. The very classical against this, see the hypoglycemia and hypoxic. The very classical about those is you will have a predominant cortical involvement with or without the deep nuclear involvement. The cerebellum is usually spared, isn't it? That's what we call as that white cerebellum on CT and other things. So this patient had some local anesthetic. Exactly, I don't remember, but there was some opioid anesthetic and something given outside. And this is a classical Chanter syndrome. The question is, which of the following MRI features most strongly supports a diagnosis of Chanter syndrome or hypoxic ischemic encephalopathy? This is for those who were putting hypoxic differential. So this will clear your some of the. So what do you think about this? Excellent. Now you have got it very right. This is bilaterally symmetrical cerebellar cortical diffusion restriction with relative cortical cerebral cortical sparing. So if you see predominantly the basal ganglia and cerebellum, but the supratentorial cortex is spared. This is very, very classical of these, and particularly in the background of some history. In fact, you have to be very sure about the history. Otherwise, nothing is classical in radiology. You will have different levels for everything. Excellent. So remember these points. Even in the hypoglycemia was one of the differentials. Hypoglycemia, again, you will have typical involvement of the cortex, very strong involvement of the cortex, with some sparing of those perironic other things. But cortical involvement will be out of proportion to the deep nuclei and the other structures. Remember this one. And this is my favorite question about the Chanter. A patient with Chanter syndrome is most at the risk of which of the following complications? I hope the response are very quick because I have put a lot of cases, so I want to show you a lot of spectrum. No, they will not have put spontaneous myelonis. Spontaneous myelonis is like kind of this osmolar disorder. Excellent. Hydrocephalus. So hydrocephalus is a dreaded complication of Chanter syndrome because they have predominant cerebellar involvement. Then they develop this compression and they develop hydrocephalus. So you have to monitor these patients for hydrocephalus. Hydrocephalus is a very prominent complication of these patients. Excellent responses. Thank you, guys. So this is Chanter is an acronym. You can see the cerebellar, hippocampal, basal nucleus, edema with restricted diffusion. That's what composes the syndrome. And there is an association between the use of drugs of abuse, particularly opioids. You may not see anesthetic history. Patient with drug abuser, particularly these days, opioids are very common drug abusers. So you have to be very cautious about this. So you see diffusion restriction findings, they are the radiological hallmark. And what is it? Bilaterally symmetrical restriction in cerebellar cortex and hippocampi with additional basal ganglia involvement. Key discriminator from HI is the relative sparing of cerebral cortex and subcortical white matter. And the cerebellar swelling can cause obstructive hydrocephalus. That's what you have to monitor these patients for. Excellent. We will go to the case number 5. These are two different images which I have put. They both look similar to me. Initially, to me, they can cause confusion. I don't know about the others, but they can sometimes cause confusion. They are not always so easy. So these are two different. See, to me, they cause confusion. I don't know about maybe. So what do you think about this first image on the left? And what do you think on the right? Then we will go to the other images and left osteosarcoma. This one. Okay, you are talking about this one. Sessile osteochondroma. Osteosarcoma left. There is an L mark. So you are talking about L mark, the osteal, first parosteal osteosarcoma. Parosteal, left osteochondroma. Second, chondrosarcoma. Excellent. Okay, lot of this is not a location for you. This is not the location, and this is not the morphology of a Noraz lesion. This on the left, if you see, you can see here the cortical continuity. So it is difficult to appreciate. I can imagine, but see, depending upon the plane where it's arising and what plane you are getting on the X-ray, so you may not be very well different able to demonstrate the pedicle and the cortical continuity on the radiograph. But this you can see here. So this one is an osteochondroma. And what do you think about this one? This one was a periosteal osteosarcoma. Paraosteal are very classical. You will see very dense bone, posterior lower femur, distal femur is the classic location. You will have a cleavage plane with the cortex, and that looks like a myocytes kind of thing. So this is periosteal osteosarcoma. On this one, somebody is saying exhaustive malignant. It's hard to say malignant change on this one unless and until you see a cortical destruction or radiograph and other things. You see a soft tissue mass. Otherwise, you have to do MR to look for that cartilage gap. But this wasn't a malignant change. This was an osteochondroma, and this one is a periosteal osteosarcoma. Okay, we will come to the next question, and you will get an idea. Which of the following is true for periosteal osteosarcoma? Excellent. See, I knew this one. A lot of people will have excellent. There's Dr. Madhav saying A. Excellent. See, this is why we most of us have confusion often at times. We see imaging, we memorize these imaging without going to the basic pathology of these lesions. See, in case of musculoskeletal, you have to be very sure about the pathology. Pathology is what reflects on your radiographs. So the correct answer is chondrogenic. They are predominantly chondrogenic. They will have osteoid component. That's why they are osteosarcomas, but they are predominantly chondrogenic. And that's the cat. They are not predominantly osteogenic. They are not mixed. They are predominantly chondrogenic. Which of the following is true for periosteal osteosarcoma? Now this one is easy. Ah, great. So there is chondroid mineralization. See, these two important things. So otherwise, if you don't know it, you will say there's osteoid or other things. But this is predominantly a chondrogenic lesion, and they have predominantly chondroid mineralization. I will just show you the image. Excellent. Just a minute. See this one? If you see here, can you see these rings and arcs? See this punctate? Even if you see periosteal reaction, but if you see the matrix of this lesion, you will analyze that there are kinds of those chondroid pattern of calcification. So this is predominantly chondrogenic. There are embedded foci of osteoid. Diaphysis of the lower extremity long bones is the typical location. They have broad-based apposition to the cortex. I hope you are able to see this arrowhead of mine. They have a broad-based apposition, and unlike high-grade osteosarcoma, they does not completely circumscribe the bone or invade the medullary cavity. Periosteal is distinct from parosteal or Osteochondromas are parosteal osteoformed by an exuberant periosteoreaction. See here, it's an extensive periosteal reaction. And important one more thing is this periosteal reaction is very random. It's not like that typical organized kind of thing which usually see in case of conventional osteosarcomas. Cortical erosion and thickening, that also you can see here, this cortical erosions. You can see the cortex here thickening. See, it is just demonstrating all the classical features. That is the powerful imaging clue. Prognosis intermediate between the parosteal and the other types of osteosarcomas. They are more aggressive than the parosteal. They have a generally radiolucent with internal areas of chondroid mineralization, which I showed you. Sarcorization of the cortex can be seen. And that is usually every surface osteosarcoma, they have that sarcorization. Even the periosteal chondrosarcomas, they have also those kind of sarcorization. And important point to remember, even if you see marrow signal, don't label every marrow signal abnormality as marrow invasion. Lot of those marrow signal abnormalities are secondary to reactive changes rather than the true infiltration in case of periosteal osteosarcomas. So the classic triad is the surface lesion, sarcorization with a sunburst. Remember these three features, and that's what gives you a periosteal osteosarcoma. This is taken from the radiographs. You can see on the CT these rings and arcs. These are chondrite. And if you do MR, you can see here predominantly hyperintense signal on fluid sensitive sequences. Now you know it why there is this predominant hyper, because this is a chondrogenic lesion. Okay, excellent. Due to hyperintensity that we discussed. The important thing is not to stop questioning. That's what I am saying. You put these comments and they are a learning for all of us. Curiosity has its own reason for existing. So keep discussing these diagnostic images and other things and imaging puzzles. That's how you will learn radiology. You will not learn radiology from the books or your desktop. You have to attend the daily clinical practice cases and other things. That's how you will learn, because they come with confusions and those confusions will give you clarity. Okay. 45-year-old female on ATT with abdominal pain. Can you show the previous slide? Oh, you are saying about the coat or the someone else? So this was an ATT outside, came to us on follow-up CT to assess the disease. That's why I'm telling you the history. This is a real life case. Patient was on ATT. She has taken ATT for 3-4 months and came for the follow-up. These are different images. So if you are sitting in your console room and the case comes to you, so they say, what do you think? Oh, the CT and MRI. Okay, okay, I will quickly go through. This is the CT. These are the rings and arcs pattern, and this is the hyper intense signal on fluid sensitive sequences. Excellent, beautiful. If somebody has celiac disease, excellent, beautiful. So that is the bullseye answer. So what was the catching point in this? Can anybody mention what is the catching point in this? Cavitary nodes, excellent cavitary nodes. Okay. These are those fat attenuation nodes, low density nodes. Why not Whipple's disease? Whipple can also have low attenuation nodes. Excellent cavitary nodes. Okay. Any other finding in this images? Bowel wall thickening. These are actually suboptimal distension. So maybe that. But these nodes, if you see, these are fat attenuation lesions. And these ones are those cystic kind of, which we see cavitary. They are not actually, this is pseudo cavitation. If you see, these are fluid density nodes with thin rim enhancement. You can see these in TB also. But important is usually you don't see macroscopic fat in case of TB. And second, when you see necrosis in TB, you will have a heterogeneous kind of enhancement. The necrosis is never so smooth. So this is a case of celiac disease, and the typical condition, this kind of presentation, what is called we call as a cavitating syndrome, mesenteric cavitated lymph node syndrome. Any other finding in this one? That will be very appreciative if somebody can pick up any other finding in this one. Excellent. Small spleen. Beautiful. So that is small spleen. See here. See how the spleen is small. Liver was enlarged in this space. And that is a very classical finding in case of the celiac disease. Remember this one. Small spleen. So small spleen along with these kinds of nodes involvement is very classical for this was a 45-year female. And on the basis of imaging, we suggested that it should be, and then the antibody panel was done, and that was strongly positive. Patient was managed as celiac disease. Okay. So these are other images of the same patient. You can see the small spleen. You can see these fluid attenuation nodes. Okay. Which distribution pattern of lymph adenopathy would argue against the cavitated mesenteric lymph node syndrome in celiac disease? It will be very quick. We have a lot of other cases. What do you think about this one? I need very quick responses so that we can discuss these causes. Beautiful, beautiful. Retroperitoneal lymphadenopathy. You don't see retroperitoneal lymphadenopathy in case of the celiac disease-related lymphadenopathy, that cavitating mesenteric lymph node syndrome. The nodes are typically jejunal. You don't see retroperitoneal nodes. The pathology is different. This is an antigenic exposure going on in the small bowel and leading to drainage pathway into the mesenteric nodes. So if you see retroperitoneal lymphadenopathy, you have to think of other pathologies like tuberculosis and other things. You don't see retroperitoneal nodes in case of celiac disease. Excellent. Okay. Which pathologic process most likely explains the development of cavitation within these nodes? I put these questions so that you get an idea that there are other things in theory which you have to know. Just to create that curiosity in you. Excellent. So that is the lymphoid depletion. What happens in these nodes? Now, these are kind of exhausted nodes, like the all kinds of radiologists. These are nodes that are exhausted. There has been long antigenic exposure going on in case of celiac disease. The lymphoid cells get depleted and other things happen. And then they fill up with those chylous fluid. So this is basically not actually a true necrosis. Necrosis is something there is a solid insult happened and vascular supply is compromised and dead. This is basically those kind of exhaustion of the lymph nodes which they fill with chyle. Which complication is most responsible for mortality in cavitating mesenteric lymph node syndrome? Excellent responses. What do you think about this one? Varying responses. Okay. The enteropathy associated to excellent. All those are possible complications in these ones. They can develop this GI bleeding. They have severe ulceroduodenal disease. They can have enteropathy associated T-cell lymphoma. Small bowel obstruction is less likely, but if they develop malignancy, they can develop other lymphomas and other malignancies, non-lymphoblastic malignancies also. But the important complication in this one, if you see the previous images and remember them, there was a very significantly small spleen. So as you know from the medical knowledge, any patient with splenectomy or compromised spleen, they are responsible. They have those capsular bacterial septicemia like pneumococcal. So they can develop overwhelming sepsis due to hyposplenism, particularly due to pneumococcal. That's why they usually get vaccination with pneumococcal vaccines. Excellent. So they commonly, if you have cavitating lymph node syndrome, patient of celiac disease, even if managed properly, they will have refractory symptoms. Remember them. This, if you have refractory symptoms in case of celiac disease and patient comes for imaging, the two, three conditions that you have to rule out is one is this enteropathy associated lymphomas, this cavitating lymph node syndrome, and other pathologies. So small bowel biopsy is the diagnostic. You have splenic atrophy. You have clinical evidence of hyposplenism. And if you do peripheral blood image, you will have these kinds of cells. And you see these multiple cystic masses which fill with the chyle. Fat fluid level, if you see, usually it's very rare, but if you see that is very pathognomonic. And as I discussed, only the mesenteric lymph node, the jejunal lymph node chain is involved. Okay. Case number 7. So guys, we are lagging behind a lot of cases I have. This is a companion case, 77-year male with abdominal pain. These are two different pathologies, same mesenteric kind of abnormality. What do you think about this one? I did a complete diagnosis in this one, not just one isolated finding. I will see who has those kinds of sharp eyes. Small bowel lymphoma, carcinoid, malt lymphoma. What a different mesenteric carcinoid with venous invasion. Excellent. That's but still not complete. Venous, that is beautiful. So there is an this is a carcinoid, mesenteric carcinoid. You can see here. It can be confused with sclerosing mesenteritis. This is the vascular involvement, and whatever you are seeing, this one is secondary to the venous ischemia. That is very common in case of you can see such kind of complications in case of carcinoids because they have that liberation of those serotonin and other things which cause strong desmoplastic reaction in the mesentery and all of these vessels. They can have this kind of ischemia. Any other yeah, excellent neuroendocrine tumor with mets, beautiful. You can see this hyperenhancing lesion here. So that was a carcinoid with metastasis with this venous ischemia kind of involvement and those jejunal involvement. Excellent. So this was a companion case. Which imaging feature is most specific for mesenteric carcinoid tumor? This is very easy. Yeah, coarse calcification within a speculated hyperenhancing mesenteric mass. Beautiful. Okay. So mesenteric carcinoids are usually metastatic, from a primary in the midgut. Whatever you see in the mesentery is not actually the tumor. That is the spread from the bowel. Bowel is usually the small one, and the mesenteric mass you usually see that is a metastatic spread. You see an oval soft tissue mesenteric mass radiating linear strands in a stellate pattern and thickened adjacent bowel loops. So that's mesenteric carcinoid. Radiating strands of soft tissue caused by tumor infiltration with fibrosis. Fibrosis and desmoid are due to the local effects of serotonin, which I was discussing. And three patterns of calcification you can see in this one: small stippled calcifications, coarse, dense, and diffuse calcification. Beautiful. Differential diagnosis will be all those which you beautifully mentioned: desmoid tumor, treated lymphoma, metastatic disease, peritoneal. Somebody is asking, are you doing arterial phase and half? We do triple phase in everyone. I know this is not the protocol in everywhere, but what we have seen is we don't usually get nice. I think it's most of the times problem with the radiology that when we read in the books that do in this, for example, lesion do dual phase or this one, but when you do see it, you most of the times the clinical diagnosis is not correct. So when you do it, then you regret that we needed arterial phase in this one or we needed delayed phase as this one because most of the times the pathology is different. We see patients diagnosed with CLD coming to us, there's peritoneal carcinomatosis. Diagnosed with peritoneal carcinomatosis, they come to us, there is some other mass. So usually we do most of the time with this triple case. I know this will not be everyone. So case number 8, child with limping. We'll quickly go through this. What do you think about this one? We have 10, 15 minutes left. I will try to show you many more cases. There isn't Scaffy and there isn't Persis. See, the images are very clear. If you see this one, see, these are the irregularities. These are the irregularities. This is the edema adjacent, edema within the bone also. You can see here. Yeah, this is a normal variant, ischiopubic synchondrosis. It can be asymmetric. Ah, yeah, beautiful. That's what if it's symptomatic, we usually call it as a one neck Heidelberg disease. This is basically an ischiopubic synchondrosis. Symptomatically, Heidelberg disease. Which of the following is true for one neck Heidelberg disease? So I have put these questions so that you get an idea that there is the theory part also related to these cases, which you have to know. Excellent. Nice answer. This affects the weight bearing leg. Remember it. So when a child is walking, the dominant leg usually you often notice that they start playing, kicking every other thing they see on the roads. So most of the time the weight is shifted on the weight bearing leg. And because of the strain of adductors and the hamstrings, they develop this kind of asymmetrical kind. It can be bilateral, but when it's bilateral, it is also usually asymmetrical because of that weight bearing involvement. So weight bearing leg is usually involved. CT is not the modality of choice. MR is the modality of choice because that will depict you the edema and other things. It can be bilateral and it does not affect the dominant leg. Dominant leg, I mean, which is more active in case of it, and which is not an imaging feature of one neck Caudal disease. Excellent. So very straightforward. Aggressive periosteal reaction with adjacent collection. If you see those kinds of things, you will suspect infection and other pathologies, but usually don't. Can see mild adjacent edema, but there is no adjacent collection, no diffusion restriction, and no aggressive periosteal reaction. This is See, sometimes they can have this tumorous kind of enlargement. It can. That's what I was saying. Aggressive periosteal reaction. Somebody may think why we will think of a periosteal reaction, but the appearance of this may not be always so straightforward. Sometimes they can mimic if it is unilaterally. See, it looks like a lytic lesion, and you can have a lot of differentials in this one for a lytic lesion. So remember those location and remember the features. So this is a temporary cartilaginous joint. This is pubic chondrosis. Asymmetry in these cases is not pathology. They may not be symmetrical, and it's a symptomatic stress-related inflammatory variant of a normal developmental process. Like previously, we used so the calcaneal apophysites, which we now know it's a normal variant. It will resolve of its own, like the Hope lesions. So if it affects the more the weight-bearing limb, and mechanical stress plus open syncondrums leads to pain and edema. There is marrow edema, but there is no bone destruction, and you can see adjacent muscle edema. These are all differentials. And the exclusion criteria is if you see cortical breach, you see permeative destruction, speculated periosteal reaction, and a large soft tissue component. I didn't show you the another case. I had another case of a patient, young patient. The only lytic lesion she had was in this ischial tuberosity in the same location, and that came out as LCH. So remember all these differentials in mind and remember the features. Okay, we'll go quickly to the case number 9. This is a 48-year male, known case of testicular tumor. Patient was on follow-up, now develops a progressive increase in the mass with normal hormones. The mass was previously there, now it is enlarging. Hormones are normal, testicular tumor. Remember these three, four features. This is one of the cases from CMC. They have published it. You can go through this article also. They have published this also. Excellent, beautiful, growing teratoma syndrome. Excellent, beautiful. So that is a growing teratoma syndrome. Nice diagnosis. Can see here vascular displacement. So that is growing teratoma syndrome. Some may not have heard about this condition. This is usually seen in case of this non-symptomatic germ cell tumors. When you give them chemotherapy, the most of the component dissolves, some mass is left, and you follow up it, it starts growing. Which of the following is the biological basis for the growing teratoma syndrome? See, there is no persistent viable cell. That's why I had put in this clinical details, the hormone levels. If you have hormonal levels still elevated, that means there is still residual disease. In these ones, the hormones are normal because there are no malignant cells. It isn't a fibrotic. Don't consider it as a residual fibrotic sequelae. It's an active process. It's a biologically organized process, not just some the residual fibrotic sequelae. It's a biologically active process. The angiogenesis is there, the epithelial cell secretion is there, the fibrovascular stroma is there. So this is because of the survival and proliferation of the mature teratomatous component. The immature component on the post chemotherapy resolves, the cells die off, and it's kind of a that cell selection by the chemotherapy. The teratomatous element, mature teratomatous element previously was there, but because of the limited space, was not getting a time, chance, space to enlarge. But the moment you put on chemotherapy, these cells get time, they get space, and they start growing. So, which imaging feature most reliably differentiates viable malignant tumor cells from growing teratoma syndrome in a post chemotherapy? I discussed this one. So, this one is very easy. Macroscopic fat can be seen in both. So that cannot differentiate it. Excellent. Rising serum tumor markers. Even that is not significant. They can usually these teratoma leftovers elements, they don't have usually PET activity, but they can show some PET activity. It is the rising serum tumor markers which are the differentiating feature. And three things you have to remember about this condition. One, in these kinds of this malignant teratomas, there are three responses which can happen. One is this growing teratoma syndrome, another is persistent malignant disease, and third is chemotherapeutic retroconversion. Remember this, chemotherapy retroconversion and growing teratoma syndrome both can look similar on the imaging. The only feature is growing teratoma syndrome will grow as the name suggests, whereas the chemotherapy retroconversion, that has a, you guys can read it. So that has a different basically biological basis, and that usually remains stable. But this one grows. So you can go through the theory. So remember these three things: chemotherapeutic retroconversion, growing teratoma syndrome, and malignant disease. So it represents an enlarging mass at the site of previous tumor deposits, most often cystic, because I told you it is biologically active. There are epithelial elements which keep secreting fluid and other things. After complete serological response to multimodality therapy, enlarging tumor is a mature teratoma. And one important thing, I told you this is secondary to the chemotherapeutic selection. So this will not respond to the chemotherapy. If you wrongly label it as a residual disease, so it will be given chemo and other things without any benefit. And surgery is the definitive treatment if it is feasible. Case number 10. So we have still 5 minutes left. This is a 54-year-old female with cough and arthalgias, no fever. These are different selected images. What do you think about this? Beautiful. These are rheumatoid necrobiotic nodules. Excellent. Looks like metastasis. Excellent. Metastasis is one of the differentials. In fact, you can put as the first one because you cannot label them as directly as the necrobiotic nodules. You have to know the clinical background. You have to know the imaging features, and you have to rule out underlying malignancy with metastasis. So there are multiple features, but one important feature, if you see multiple nodules, if you see peripheral nodules, if you see nodules touching the pleura, you see cavitation, you see sharp margins. These are some five, six features. And they say if you see three or more than three out of these, this is usually suggestive of rheumatoid nodules. Remember thing, just to put you in the background, you can see here evolving cavitation in this one, but metastasis definitely, in fact, the first differential in this one, unless and until you know the background and other things. And this was the same. See, this was in our QU. Why we just straight away said that this is most likely the rheumatoid. This was the dislocation. You can see here. There were erosions. You can see here erosions also. And this was the hip pelvic radiograph of the same patient. So putting all these three things together. So you have to think about the point is you have to think about the diagnosis, then start searching. It's not like they will things will come out and pop out at the screen. You have to suspect something, and accordingly you can image the patient further. So this is rheumatoid arthritis and rheumatoid nodules. Which imaging feature most strongly supports the diagnosis of pulmonary rheumatoid nodules rather than metastatic disease? Excellent. That is waxing and waning appearance. So I told you there are a lot of pathologies in the human body which have this waxing and the first case we discussed was that visceral larva migraines. The pathology will evolve over time. Same as this one. If you follow these patients, the pathology will evolve over time. That is usually seen in vasculitis and other things. Lot of pathologies. So if you see a waxing and waning appearance, some nodules disappear on their own, some new nodules appear. So that is very, very classical for these rheumatoid nodules. Which complication is most likely to occur in rheumatoid nodules? They can develop a lot of these complications, but pulmonary hypertension, unlikely unless there is a pulmonary disease to some other things. The typical is pneumothorax because as we were discussing, they develop cavitation. And not only cavitation, I told you these are peripheral and they touch the pleura. So if something cavitates close to the pleura, obviously they will have pneumothorax. So remember these pathologies, why and why they occur. That's very important. So these are extraarticular manifestations. You can have subcutaneous nodule formation. You can have vasculitis, inflammatory eye disease, lung disease. Respiratory symptoms can be because of the parenchymal involvement, pleural involvement, airways, vasculature. And pulmonary involvement is because of the common chronic immune activation. They have increased susceptibility to infection because of immunomodulatory medications. Or you can have direct toxicity from the disease modifying drugs. Rheumatoid arthritis related ILD is the most common form of pulmonary involvement. Rheumatoid nodules occur in long-standing disease, and those with subcutaneous nodules, typically located along the interlobular septa or in subpleural regions, they can be single or multiple, few millimeters to several centimeters, may cavitate and rupture, most involve the middle and the upper lung zones, and little or no uptake on PET-CT. I didn't show you the PET on this one. We had done PET in this one, still to rule out an underlying primary. So hallmark characteristic is the waxing and waning behavior. They may increase, they may decrease, they may cavitate, or they may completely disappear. Migratory behavior, this what we discussed, is very, very suggestive, and that's what helps us differentiate these from malignancy. This is a companion case. I told you, showed you the Panus in case of rheumatoid. This looks like similar, but this is kind of what we call as a pseudotumor. But this pseudotumor was not secondary to the rheumatoid. You can see here, this was an os odontoideum. This patient had chronic instability secondary to that, and the Panus, this hyperplastic response gradually developed to that. I had another case, but I didn't show you at this one. So there are a lot of things which can happen on this one. Yeah, cord changes are also there, myelopathy. That is expected in these ones. They have a dynamic kind of, even if you don't see cord compression in these ones, but once you flex and extend the neck, they can have these cord changes because of their dynamic response. So this was secondary to os odontoideum. Simplicity is the ultimate sophistication. Radiology is extraordinary complexity. Thousands of shades of gray, subtle patterns, and endless differentials. Yet the real mastery is not in making things complicated, but in distilling complex imaging into clear, simple understanding. And perhaps the most important lesson in medicine is humility. And that's my request and advice and the point to be taken for today's lecture. Be very humble in your practice. No matter how experienced we become, there will always be someone who knows more, who sees something we miss, or understands a pattern more deeply. That humility is what keeps us learning, questioning, and ultimately improving the patient care. So, time is up. I had a lot of other cases to show you, some five, six cases more. Dr. Nikshita, are you there?
Yes, yes, I'm here. Um, I'm excited to see the other cases. If that's okay with you, we could probably
No, no, I
extend.
can, I can. Yeah, yeah. If others are okay, I can.
Yeah. Maybe we'll not take
So,
questions today and we'll just see more cases, if that's okay with you.
okay, okay. I will go with two, three cases more. Okay.
All right. Thank you.
Thank you. Okay, this is case number 19. 11. This was a 59-year female with post-menopausal bleeding. These are different MR images. What do you think about this? Excellent. C endometrium, adenomyosis, metastatic endometrial CA. Excellent. Very good differentials and very nice. And let me tell you the fact. This patient came to us. It was outside diagnosed as adenomyosis on ultrasound. And when I saw this first this MR, I was also, this is like an adenomyosis. So there is a lot of adenomyosis. But the only thing which was kind of bothering me was this, if you see the junctional zone here, here it wasn't looking something like something is destroying and something is invading that junctional zone. It was not looking very good. And the more trouble was there was diffusion restriction. Normally you can see diffusion restriction or other things, but this was bothering that the same area which is showing this loss of this layered pattern here is showing the diffusion restriction. And under guarded report, we suggested that this is adenomyosis, but there is suspicion that there is probably some malignancy. And I wasn't sure whether this is coming from endometrium or is it within the adenomyosis, because I couldn't really appreciate the endometrium very well. And based on that, the patient was finally operated. He was, that is the important thing. The patient was, she was anyways planned for hysterectomy because the bleeding was there. But once you say there is suspicion of malignancy or something, the treatment plan changes. You have to do lymph node dissection and other things. So it went to the oncosurgery and patient was operated. And this was adenomyosis with malignant degeneration. No endometrial CA. This was an adenomyosis with malignant degeneration. And it is very, very rare. In fact, this is only the first which one case which I saw. So remember this one, this adenomyosis with malignancy. Remember the junctional zone. If you see there is the junctional zone is not looking very well, be very cautious about this adenomyosis. Which of the following statement is most accurate regarding adenomyosis? Very less responses. I hope everybody, I want to see a lot of responses. Excellent. Okay. See, that's why I had put this case because a lot of times we have this confusion that junction zone more than 12 mm is diagnostic. Nothing is diagnostic in adenomyosis. That's why there are other ratios also like junction zone to myometrial asymmetry, age-related junction zone ratios, and other things. So even if you more than 12 mm, it may not be adenomyosis in a particular part of the cycle. So there are a lot of hormonal changes going on. And the thickening is not primarily due to fibrosis. So that's not fibrosis, that's a smooth muscle. And even if the junctional zone is less than 8 mm, you cannot exclude it. Remember this one, even if the less than 8, you cannot. So the only true option is that physiological uterine contraction can mimic an adenomyosis, particularly an adenomyoma. Rest, all other things can be there. So it may not be diagnostic. So remember these things. So these are little things you have to remember those kinds of things. And this is a companion case which I wanted to show you. See, this is now, can somebody say what is the diagnosis here? The companion case. No, this is endometrial cavity. Somebody's maybe the image is not pretty well. This is actually the axial section in the upper part of the endometrial cavity. This area is this one on the sag, which is on the axial looking like this. Yeah, this is an adenomyosis, and this one is an adenomyoma. You can remember the classical adenomyoma, heterogeneous signal with lot of cystic spaces, minimal mass spec compared to the size of the lesion. But that's not why I showed you this case. If you see here, can you see this heterogeneity? This was an adenoma. You can see the enhancement also. The hypoenhancement in case of you compared to the myometrium. This was an adenomyosis with endometrial CA. So that's why I showed you this case. The previous one while adenomyosis was malignant degeneration. And there are certain important differences when you are interpreting these endometrial CAs. One is the depth of myometrial invasion. For example, the previous case, like this one, if, for example, we consider it was an endometrial CA, it's very hard to appreciate the depth of myometrial invasion. And that is one of the pitfalls which is difficult in these cases. So malignant transformation, the most commonly associated cancers are endometrioid carcinomas, clear cell carcinomas, adenosarcomas, carcinosarcomas, and Mullerian mucinous borderline tumors. There are some of the criteria which must be met before you say adenomyosis with malignant degeneration. And these are those kinds of, basically the aim of these criteria is to rule out that there is not an underlying endometrial CA with myometrial invasion. That's why I showed you the two companion cases. And what this is what I was discussing, that indistinct endometrial myometrial border, and that reduces the MR-based evaluation of the depth of my endometrial adenocarcinoma invasion. And it can cause pseudo widening because of the normally if you see adenomyosis when you are doing ultrasound, the endometrium on ultrasound looks like 12, 13 mm, but when you do MR, it's 2, 3 mm. That is because of those hyperechoic striations, and those hyperechoic striations or hyperintense striations, they can mimic the invasion of an endometrial carcinoma into the. That's the difficulty we face in case of this adenomyosis. Case number 13, I think this will be one of the cases we will end with this one. We'll be getting late. So this is 10-year male with chronic pain in thigh, no fever, TLC is normal, CRP is elevated. These are the different images. So what do you think the diagnosis in this one? Brody's, osteoid osteoma, chronic osteomyelitis. The very important differential in this one is, in fact, the first thing you have to rule out is chronic osteomyelitis. There are some of the clues. One is if this one is basically a chronic recurrent multifocal osteomyelitis, which we presently call as an NBO, non-bacterial osteomyelitis. But before labeling it as a non-bacterial osteomyelitis, even there are a lot of imaging features which will be suggestive, but you have to rule out bacterial osteomyelitis. And that's why most of the times these patients undergo biopsy of these lesions unless and until you have other supporting features, like you do stir whole body and you see multifocal involvement and those kinds of things. That's why in this one, infection markers were negative, inflammatory markers were present, and all those features putting together, and the MR features which are thought to be very suggestive are these kinds of intermediate serpiginous areas within this. You can have periosteal reaction, you can have mild edema adjacent to it. These are the pathologies. So this is a chronic non-bacterial osteomyelitis, but you have to rule out bacterial osteomyelitis in this one. That's why I showed you this case. Which imaging feature most strongly favors CRMO over infection or malignancy? Excellent. Lot of mixed responses, but somebody rightly said this is, you can have, see, marrow edema can be seen in a lot of conditions. Osteoid osteomas, chondroblastomas, multifocal distribution can be seen in metastasis, multifocal osteomyelitis infective. It is the medial clavicular involvement which is very, very suggestive of this chronic non-bacterial osteomyelitis. Lack of periosteal reaction, neither support nor rules out. You can have infection without the significant periosteal reaction. So that's what, so that is the CRMO or infection or malignancy. And if you have a spinal involvement of CRMO, which MRI feature reliably differentiates CRMO from pyogenic spondylodiscitis? Excellent. That is the preservation of the intervertebral disc. Because the pyogenic spondylodiscitis starts from the disc. isn't it? And then it goes to the vertebrae. So if you see preserved intervertebral disc with multifocal vertebral involvement, you have to think of this CRMO kind of pathology. So remember these features and remember what excludes and what favors these pathologies. So this is a sterile autoinflammatory bone disorder with inflammatory bone lesions and no infective organism. Female predominance typically manifests in the first decade of life. Serpiginous lucences, which I was showing you, those intermediate T1 and T2 signal intensities within that thickened cortex and medullary cavity. Common sites include long tubular bones and clavicle. It can involve a lot of other sites. Involvement of the lower extremity is 3 times more common than disease in the upper. Tibia is the most common bone involved. Most common sites are the metaphysis or the metaphyseal equivalents, and no extension of disease across the intervertebral disc space. That's what we were discussing also. Multiple non-contiguous vertebral bodies with sparing of the intervertebral disc differentiates this pathology from infective spondylodiscitis. And differentials include, which we discussed, the LCH, Ewing sarcoma, SAPHO, and other kinds of pathologies. And this is what I was showing you. This was one of the radiographs. This was the case sent to me. So this you can see. See this huge clavicular involvement. Remember this one. That if you see this medial clavicular involvement, sparing of the lateral clavicle and other pathologies, rule out you have. So first you have to suspect it. Then only you will do radiographs or other imaging of the other parts. And remember this, it has a unique tendency to involve the clavicle, which is an uncommon site for hematogenous osteomyelitis. Most common disease process, in fact, to involve the medial clavicle is CRMO, and it should be considered in the differential diagnosis of sclerotic expanded lesion affecting the medial third. And infection, remember this one, infection hates the clavicle, tumors try to avoid it, and CRMO loves it. This is a companion case. This was an osteoid osteoma intramedullary. And this, if you see this one, see, don't confuse this one with sequestrum. It can be confused with sequestrum, but routinely we think of osteoid osteomas as some kind of round nidus, but osteoid osteomas can have linear kind of nidus also. They can have linear, no, long nidus. All this is nidus only, and this is that nidus within which the central calcification. So everything is nidus. This was an intramedullary osteoid osteoma, which can mimic this CRMO, and there can be this chronic osteomyelitis and other pathologies which can mimic this one. So I had some other cases, but I think that's too rare than Dr. Nikshita.
Yes. Okay. Thank you so
Can
much,
we conclude?
Tamim. It was an awesome class. We had such interesting cases, and I got really excited about chanters. I'm sorry, because I also saw chanters this week, and I didn't know much about it until the clinician asked me to think of it in one child who had history of CPR, but also had history of heavy opioids for pelvic rhabdomyosarcoma, and we really couldn't differentiate the two because we read in one AJNR article that in children, cerebellar involvement is not as common in chanters, but more common in HI. But honestly, that diagnosis is still unclear. But it was an amazing talk, and thank you, Dr. Tamim, for your time and for all your excellent cases. We hope to have you again, of course, but we will give you some time to recover from the
It
two
was
back-to-back classes you have taken for
no,
us.
no. It was an honor. It was an honor. It was really my pleasure to be here. It's always interesting to be here.
Thank you so much, Dr. Tamim.
Thank you. Thank you.
Good
Thanks a
night.
lot. Thank you, everyone. Thank you, everyone. Do share your responses and do share your
Yeah,
any comments.
everyone's just sending in a dozen compliments and so many thank yous, and I had so many people write, please continue. So yeah, I think you are a certified hit. You are actually our first faculty from Jammu, so yeah, you have a lot of credits to your name in Cafe Rongent Ref.
Thank you. Thank you. That was an honor. That was an absolute honor. And I will be very happy to be here anytime with
Yes,
some new
for sure.
cases and some new points and something.
Yes, we're very excited to learn from you. Thank you, Dr. Tanu.
Thank you. Thank you. Thank you. Thanks a lot.
Record